Welcome, everybody. Welcome to the Implementation Toolkit for Small and Sick Newborn Care. Today, we're having an exciting webinar focusing in on retinopathy of prematurity at risk neonatal follow-up. Welcome. Please introduce yourself in the chat. Next slide, please. So the Newborn Toolkit is a multi-country, multilingual learning platform for high-quality small and sick newborn care. We have had over 50,000 unique users in the last 12 months from over 170 countries, and it's all thanks to our viewers and the users of the Newborn Toolkit. We've had regular webinars this year linked to evidence to action. The toolkit is available in 11 languages and is available in French as well, and is linked to community of practice in English and French. On the screen now, you see a QR code that you can use that can link you to the Newborn Toolkit social media channels, as well as newsletters that you can subscribe to. We have had, next slide, please. The Implementation Learning Seminar Series is a learning platform for our Newborn Toolkit community, and it aims to encourage collaborative learning for faster progress together. Our 2024 webinar series is structured around the WHO UNICEF 10 core components of small and sick newborn care, and today's topic is on focusing in on retinopathy of prematurity at risk neonatal follow-up. We have an exciting lineup of experts in retinopathy of prematurity, and we're happy to have you join us today for this webinar. On the screen now, you see QR codes to our newsletter in English, our newsletter in French, and you can also follow us on our social media channels. Next slide, please. So we have at the moment a Newborn Toolkit essay ongoing. It's a Newborn Toolkit contest that closes on the 11th of October. Last year, we had the first ASA contest with winners from Zambia and Burundi, and we have exciting prizes for our essay this year. So that would be £500 and a certificate. You would get published in the Journal of African Neonatology. And also we have some exciting networking opportunities that would be being profiled on the Newborn Toolkit webinar, and an opportunity to participate in your neonatal relevant conference, and a guest spot on the Incubator Global Neonatal podcast, which I co-host. Next slide, please. Welcome once more to the Implementation Toolkit for Small and Sick Newborn Care webinar focusing on retinopathy of prematurity. Next webinars we have are on November 12th, which will be the Toolkit's birthday, and we'll profile the essay winners and share key updates. On November 19th, we have a French community-focused webinar where we'll share key updates linked to the essay winners and our partnerships. And December 4th, we launch our research funding map, which will profile research partnerships and implementation research. Our webinar today is being translated to French, and you'll see that you can listen to this webinar in French on the globe at the bottom of your screen. Welcome, please introduce yourself in the chat. And now I'll hand over to Lauren.
Thank you. Alors, bonjour et bienvenue à tous nos participants parlant français. Veuillez vous introduire dans le chat en indiquant votre nom et votre rôle. Et si vous voulez écouter le webinaire en français, s'il vous plaît, cliquez sur le bouton en bas de l'écran pour accéder à la canal français. On a aussi quelques événements à venir. Sur le 19 novembre, la communauté de la langue française mise à jour de la boîte à outils pour les nouveau-nés et partenariats. Et le 4 décembre, lancement de la carte de financement de la recherche, partenariat de recherche et recherche de la mise en œuvre. So a big welcome to our host for today, Dr. Yisha Malik. Dr. Malik is a clinical assistant professor in child eye health at LSHTM and a pediatric ophthalmologist. Her research focuses on integrating eye care into child health programs and policies. She is leading the development of telemedicine and artificial intelligence screening model for retinopathy of prematurity in Nepal. Previously, she has led ROP network across 6 countries in Africa and Asia. Her research also focuses on the development of a model for integrating eye care into primary care, including innovative low-cost devices in Tanzania, which resulted in national policy change. She's now co-leading an NIHR-funded series of projects to evaluate a child health systems approach in Tanzania and Nepal. So we're very excited to have her today here to be hosting our webinar. So without further ado, I will pass over to Dr. Malik.
Thank you so much, Lauren, for that introduction. And I'm really delighted to be here and to welcome you all to this really important webinar on ROP. It's great to see the NEST and the Newborn Toolkit highlighting ROP at this time. It's an issue that I'm really passionate about alongside everyone here on this webinar, and many of you joining as well. And as you know, it's really critical time for us all in the newborn community, and knowing now that we have these knowledge and tools to prevent and treat ROP. So really preventing a lifetime of blindness for these children. So the timing of this webinar is really incredibly timely, and we are really privileged to have really some of the best of global ROP expertise joining us today to talk about the key current issues in ROP, giving us all the benefit of their knowledge and experience. I know much of our audience will also have a wealth of experience in neonatal care and ROP, so please do I want to encourage you to introduce yourselves in the chat and to post your comments and your questions throughout the webinar for all the speakers individually and also for the panel in general as well. So without further ado, I really want to get straight into handing over to our really incredible list of speakers. Our first speaker today is Professor Claire Gilbert. And for those of you who know anything about ROP, she hardly needs any introduction. She's a global leader in ROP with 3 decades of child eye health research in low and middle income countries. And in particular, she's led some landmark studies on ROP. She's played a really key role in developing regional guidelines for ROP in Latin America and India, and she has been inspiring ROP globally for many years now. So I will just hand over now, I think next slide please, to Professor Claire Gilbert.
Thank you very much, Aisha, and good morning, good afternoon, everybody, wherever you are, and thank you to the NEST team for this opportunity. Next slide, please. I'm going to talk about the burden of retinopathy of prematurity, priorities for action and innovation. Now you're going to see several photographs of children who are blind from ROP, and if you look carefully at this child's eyes, you can see a white reflex in the black central pupil of the eye. And what you're seeing is the detached retina, which is pulled up, right up behind the lens of the eye. And this child is now irreversibly blind. Next, please. Several epidemics of blindness have been described, starting in the 1940s, mainly in the USA and in Western Europe. And this was because neonatal intensive care was just starting up, and people didn't realize that oxygen was very toxic to the blood vessels in the developing retina of preterm babies. And many thousands of babies became blind before the role of oxygen was fully appreciated. And then oxygen was used more carefully, and everyone thought that that was a disaster that had passed. But then as increasingly preterm babies started to survive, they started to develop blindness from ROP. So that was a second epidemic in around the 1980s in high-income countries. In the 1990s was the first treatment trial, and now in high-income countries, ROP blindness is uncommon, it can occur, and that's because high-quality neonatal care is preventing the serious stages of retinopathy of prematurity, and there are good services for detection and treatment of the babies who do develop severe disease. So the take-home message is that blindness and visual impairment from retinopathy of prematurity is largely preventable, but it requires a team approach. People who work in neonatal units, as well as the eye care sector. Next, please. Back one, please. So every year, 32,000 preterm babies become blind or vision impaired from ROP. And that was the estimate from 2010, which we're currently updating because we feel that although some countries are getting control of blindness, particularly in Latin America, as you'll hear, the third epidemic is now happening in Asia and now in sub-Saharan Africa. And this is because of the expansion of neonatal care, often, unfortunately, of inadequate quality for whatever reason, which means that babies are exposed to potentially modifiable risk factors. And as yet, there's low coverage of ROP screening and treatment services. And along the bottom, you see the birth weight of babies who are now most at risk of ROP in this third epidemic. And it ranges from the very, very preterm up to really quite mature babies, up to 2,500 grams. Next, please. This is where those ROP blind and visually impaired babies were in the year 2010. The dark blue wedge is the babies who are blind, and the darker blue is those who are visually impaired. And I anticipate that the revised estimate for 2020, which we're just embarking on now, this map will look very different, with more in African countries. Next, please. For those of you who are not familiar with retinopathy of prematurity, the slide on the left is a normal retina with normal looking blood vessels. And the slide in the middle is severe ROP, which is sometimes called type 1 ROP. And without treatment at this stage, 15% of babies will go on to total irreversible blindness from detachment of the retina, which is what you see on the right. And this is usually affects both eyes symmetrically. And when you've got a scrunched up retina like that, there's nothing that can be done. Next, please. So in retinopathy prematurity, only occurs in preterm babies who've received intensive neonatal care. So they are a captive audience. We know where they are, and we know which babies are at risk. And they are at risk because the blood vessels in their retinas are not fully developed at birth. And then if they are exposed to risk factors, particularly hyperoxia, but also sepsis and other things, then those blood vessels stop growing initially, and then they start proliferating and growing abnormally. And it's that abnormal vessel growth, which is retinopathy of prematurity. So the purpose of screening is to find babies who've got retinopathy of prematurity, and particularly to identify the babies that have got the mix of clinical signs which suggest progression to retinal detachment. And then those babies need urgent treatment within 24 to 48 hours, ideally. And that treatment is highly effective at preserving sight. Next, please. So the main risk factors for ROP are listed here. I expect many of you will be familiar with many of them. Thrombocytopenia is a recently identified risk factor, which was actually detected by our last speaker from India, Dr. Anand Vinikar. And then general instability, so lack of antenatal steroids, hypothermia, and kangaroo care, all increase the risk, probably indirectly. Next, please. So as you can see, all these blue highlighted risk factors are potentially modifiable by high quality neonatal care from immediately after birth. And this greatly reduces the risk of the stages of ROP that need treatment. Next, please. And there are a few interventions which reduce the risk. I've already mentioned a course of antenatal steroids. I've put delayed cord clamping in brackets because it's not absolutely apparent whether that intervention alone is beneficial. But oral caffeine has been shown to reduce the risk of severe ROP in several large-scale clinical trials. Breast milk from a very young age promotes growth and failure to gain weight. is a risk factor, and I've talked about kangaroo mother care already. So there's a lot that can be done to prevent ROP. Next, please. Screening needs to be done on time, and it's usual for this to start around 4 to 6 weeks after birth, because this condition is not present at birth. It develops in the postnatal period, and the screening may need to be retreated at 1 to 2 weekly intervals, depending on what the findings are. And screening can be stopped when it's safe to do so, and there are guidelines which describe when it's safe to stop. Now, it's important to note that screening is often needed after the baby's been discharged from the neonatal unit, when there's all the problem of them coming back and the parents maybe not understanding why they need to do that. And so what quite a lot of people are doing, particularly, I'm not sure if Anand's going to mention this, but having the first screening before the baby leaves the unit is a good idea. It raises awareness amongst the parents. And some babies, if their blood vessels look completely normal and fully developed, they don't need to come back for any more screening. And screening needs to take place on a regular time and place, so that everybody, the neonatal team and the parents, know where the screening is taking place. This is very important to ensure that this repeat screening can happen. There are two broad ways that screening can be done. On the left, you see an ophthalmologist using an indirect ophthalmoscope, so that's a light source on their head, and then they're holding a lens in front of the eye, which focuses the light on the retina. And that gives you a very nice aerial view. Increasingly, digital imaging is being used, and on the right, you'll see what's called a Forest camera, which is produced by a company in Bangalore, again with lots of input from Anand Vinikar. And this is a technician taking the images, which you can see on the screen. Those images can then be saved and read and graded remotely by an ophthalmologist. Next, please. There's a mixture of clinical signs which indicate that treatment is needed. And the key ones are when you have this raised ridge of tissue which has got blood vessels growing within it. And that's called a vascularized ridge, and it's stage 3 ROP. In the right, you can also see that the retinal blood vessels are a bit more squiggly and more dilated than they are normally. And that's another important sign indicating that progression to retinal detachment is likely. Next, please. I'm just showing this is another slide of the same thing. So markedly dilated tortuous blood vessels. And this is a subset of type 1 ROP, which progresses extremely rapidly. Next, please. Treatment needs to be urgent. The initial treatment was cryotherapy, but that's no longer used. So the two main treatments now are either laser treatment, which is what is happening on the right, to the peripheral part of the retina where there are still no blood vessels, or injection of agents which block the proliferation of abnormal blood vessels. And these are called anti-VEGF agents. And these need to be injected into the back of the eye. So really a lot of ophthalmic expertise is needed for both of these treatments. But if delivered well and on time, both can be highly effective. Although babies who are given anti-VEGF agents need much more regular and frequent follow-up after treatment to make sure that the disease does not recur, in which case it needs to be treated again. Next, please. So the major innovations in ROP over the last decade or so would be the imaging system and remote image reading by ophthalmologists, so telemedicine. And this is really changing how services can be provided and has a great potential to increase the coverage for screening, as we'll hear from Anand. Anti-VEGF agents are quicker and easier to administer than laser. And it seems that there were some concerns that these agents may be damaging to developing organs, such as the lungs and kidneys, but as yet there's no firm evidence to support this. And the most exciting thing really on the horizon is automated image analysis using artificial intelligence. And there are now several groups working on this, and this really does have the potential to be a game changer. So if you can have a technician taking the images and then image grading done initially by artificial intelligence with input or with a cross-check by an ophthalmologist, this will really make the whole screening process much quicker and more efficient and effective. Next, please. So the role of the neonatal team is absolutely vital because you play such an important part in preventing retinopathy of prematurity by avoiding all those modifiable risk factors. Another important role is that the neonatal team should identify all babies who should be screened on admission to the hospital. And many countries now have got their country-specific birth weight and gestational age criteria. So in some countries, it's less than 34 weeks gestational age, in others it's less than 32, in others it's less than 31, and the birth weight criteria also vary. So it'd be good to find out if there are country-specific guidelines, or if not for your country, then maybe in another region. Babies who become very sick, who fall outside those criteria, can be added to the list. Health education and counselling of parents of the need for screening is of paramount importance. This probably needs to be done several times, verbally and with written materials that are accessible. And it's very good to establish good relationships with the ophthalmology technician team. And then on the screening day, they can, neonatal staff can prepare the equipment, dilate the pupils so the babies are all ready when the ophthalmologists come to examine the babies. They can hold the baby still, hold their head steady during screening. They can document the findings and the data of further screening. And importantly, they can counsel the parents. So what do the findings actually mean for their baby? Next, please. So thank you.
Thank you very much, Professor Gilbert. That was an incredible talk to begin with, summarizing all the kind of burden of ROP and the important actions. And now I'm really excited to be introducing Professor Dupe Ademola Papula, who I've worked with for many years now. She is a pediatric consultant ophthalmologist at the University of Ilorin in Nigeria and a really pioneering leader in ROP in Africa. She's been supporting colleagues across Nigeria and other African countries in ROP, and she is now global advisor to American Academy of Ophthalmology as well. So again, without any further ado, I'll be handing over to Dr. Dupe. Next slide, please.
Thank you so much for having me. If you don't mind, participants, please let me take off my video so that the internet remains good through. Thank you very much. Like it has been said, I have no disclosures with respect to this presentation. And you would see the next slide showing what the story used to be with many of our centers, and perhaps still now we have children sharing a bed and oxygen on the wall, oxygen concentrator also somewhere on the floor, giving oxygen to this baby without a monitor. Please go on. Next slide, please. So we found out doing this, ROP, blindness, was something that we had to contend with. These precious babies, they were real babies that came into our practice. Next slide. And so what has worked over the time, I will just go through some of them. Next slide, please. You'll see that we have moved in some of the centers to being able to have a better picture to show you today. I will just describe the extreme of our cases from the two cases I'm going to show you. This one showed a 25-week gap who came to our center at 9 weeks of life, having traveled 8 hours by road to be able to have ROP care. And on arrival, this was what we saw. We had hybrid ROP. We already had some lift in the retina. But fortunately, this baby stayed on for a while with us and were able to get this eye returned to normal. The next slide will show you an unfortunate case that also traveled similarly. Next slide, please. Traveled similarly to access care because this child did not have ROP screening. The first one had ROP screening at the center, but they had difficulties with treating. They sent. This one did not have ROP screening. And of course, we could see that it was a twin. One twin had cicatricial ROP, as you can see here, already retina discharged, but the second twin did not have ROP. The baby also traveled from 146 kilometers closer to us, 3.5 hours, but because no screening, that baby had blinding ROP, just to show how having a screening program, what it can change in the situation of a child. Next slide, please. The next slide just shows some of the things that has worked for us over the time. Various publications that we did. Identifying the challenges with our screening, not having a coordinator, not having something to monitor the oxygen, and not being able to follow through, and of course, missing babies. The next one showed the national publications that we had, which is something that still continues to work, that showed that between 3.5 and 7.5% of our babies would have type 1 ROP, depending on the cutoff that we use for the gestational age. If we use 34, it will be about 3.5. If we use less than 32, it will be about 7.1. Next one. As we look forward together on what works, these are the things that will continue to work in every country that we go to. People must be looking at their data. We go on further to say, okay, now we know what we have. Next slide, please. What are the problems? We are now screening. We began to look at babies, and we found out that missing appointment was still a major thing in our centers, even though we have screening program going on. So what did we do with that? What works? We started weekly audit. Next slide, to capture every child by the ROP coordinator, not just the NICU alone, so that we would be able to know at the end of every week if any baby has indeed been discharged without being screened. The next slide showed that as we continue to look at these various data, we'll see babies who, though we say, oh, before their discharge, babies who came at 2 weeks, who were screened at 3 weeks because they wanted to be discharged or whatever, and they had type 1 ROP that required treatment. Next slide shows us the study that about babies who had become blind, 18 of them that had become blind from ROP. And we were surprised to see that 33% of these babies were born and nursed at private institutions. And that informed the implementation of ensuring that in such institutional advocacy that they're able to put into practice screening. If you're going to take care of the baby, ROP screening must be part of it. Next slide. Continues to show us that few of the people are still available to screen for an ROP across Africa. The challenges, some of the challenges that we have had are transportation. If we want to move things from here to there, we have to keep thinking about it. If you notice, one baby just for 365 kilometers traveled 8 hours. That tells us something about the road. And it is expensive where available to have air travel, and it's not even well developed. We do not have enough train services in country or inter-country. Those are challenges in Africa. And so what we must implement must be what is possible, so that as many centers as are possible are able to screen in their center. Next slide, please. Next slide for me. Fortunately for us, we should say, maybe not for the babies, we have few litigations happening because sometimes this is a driver in some countries. But we got close to having some in Nigeria. I don't know what has happened in some other country. I know South Africa had some. And this has helped us to try to ensure that we do the needful. And we have varying complexity in our resource allocation and regulation, who can do what. For example, in some countries now, we will talk about technician screening. That may not work in some country because of regulation. Nurses, minimal, they will be the one to screen. These are the issues when we are talking about implementation that must be considered. Next slide for us. We also have had some of the things we know worked in the past and we continue to work. I will highlight them now with this set of next slide. Please go on. Go on. Communication. We have that going for us in Africa. Good penetration of mobile telephone network with some reasonable internet infrastructure, which has made available to us ability to have professional chat groups. We have that. We use WhatsApp commonly. This helped us to disseminate information on various things around ROP, including supporting one another, alerting on babies who are blind, some posting about babies who showed up at some hospital who are already blind, and helping us to identify hospitals who require support. In every implementation, this is an important one, whichever country, people getting together and talking continually one with another. Next slide. Education. When we have regional, national leader at various institutional level talking together, which we continue to do in Africa, we have a platform that has over 200 members that we call Stop ROP Africa, where we have different people there doing all manners of things. We also even started International ROP Journal Club. We said we set out a target to have that every 2 weeks for 6 months and once a month for 1 year, which was done. And that brought many people up to some knowledge, up to some experience in ROP. And this groups continues over the time where we continue to encourage one another. Education, which I have on my next slide. Specialist education, webinar like we're having now, another webinar including hospital grant rounds, patients education, research, and publication is an important implementation so that people will know what the situation is at every point and be able to take important decisions. Conference presentation, training of nurses, medical students, other allied workers, and being deliberate about dissertation thesis at our postgraduate level, and pediatric fellowship that are already available on the sub-region. And of course, participating in research into low-cost camera. We have some of them all around. International Journal Club, and advocacy, like we had a mother who had to go, who refused screening, but then went ahead to spend 38,000 pounds to care for the child somewhere. So these are the things that we have found to have helped implementation, and they will continue to help. Again, next slide shows referral. Supporting interinstitutional referral where you're unable to manage a child, getting this patient, having referral pathway created so that babies can move from place to place, discussing across, do this, even using video to support one another when the child cannot travel, to say, okay, do it like this, do it like this, and then this has become a game changer. I say that having a camera is the greatest game changer any institution can have, and I'll support getting whatever it will take for every institution in Africa, every hospital that sees babies who are born premature, to have a camera, because it just simply allows people to share images.
Oh, I think we seem to have just lost Dr. Dupe from the call. So I think what we might do is we'll give her some time just to rejoin. But I think because of the timing.
Don't mind the internet. The internet is misbehaving, but then we are almost through.
Yeah,
What
I think
has
you
also...
have just, if Dupe, you could just conclude within a minute, if that's okay, just to give the other speakers.
Okay, so in conclusion, our ROP story has moved from being very basic to at this point being able to talk with one another, audit our data, and looking forward to a situation in which every institution that sees a reasonable number of baby is able to use a camera or a smartphone, take picture, share, and get support from wherever, so that we stop the needless blindness from ROP in Africa. Thank you very much.
Thank you so much, Dr. Ubu, for that really comprehensive talk. And I want to now go on to, if we can go on to our next slide, please. And just remember, everyone, there's a Q&A box for all our speakers. You can put specific questions in the questions, the Q&A box, and also any general questions you have for the panel at the end as well. So thank you once again. To Dr. Dupe. Now I want to introduce Dr. Juan Carlos Silva, who is a public health ophthalmologist and a leader in ROP in Latin America. He's been a former advisor for eye care at the Pan American Health Organization, which is a regional office of the World Health Organization. He studied medicine in Colombia and completed his fellowship and master's degree at Johns Hopkins. And we're delighted to have Dr. Juan Carlos joining us today. Thank you.
Well, thank you very much for the invitation. For me, it's an honor to be here. Next slide, please. Okay, so we decided to present the milestone that we had in Latin America. The first part, what we did was the evidence, the magnitude of ROP. At that point, we don't even know that the ROP was a big problem in children. Then once that was done, then we started to set up national committees with professionals and associations and the ministries of health to try to tackle the situation. Then we decided to produce clinical guidelines, which was a very important step, but was followed by policies that included human resources, financing, screening mandatory for neonatal units. And then we started the data collection. From the very beginning, actually, we started the data collection, which is crucial. Next one. The first part was giving the evidence on the problem, and that was helped by Claire Gilbert. She came a long time ago to discover the proportion of blindness caused by ROP in several countries. The first country was Chile, which 47% was due to ROP, and then Guadalajara in Mexico, 35%, Sao Paulo, 11%. So that means that the proportion of blind children due to ROP was extremely high. So we were alarmed, and then we started to do things to solve the issue or to tackle that. Next, please. Next. So our approach was strengthening the health systems. This is a picture of how a health system works. It is composed of norms, of standards, of services, development, and more recently telemedicine devices and medicine as well. The workforce, which needs to be strengthened, and the financing, of course. So that was the approach that we follow. It is like a puzzle. You have to put all the pieces together to really get some results. Next. One of the key things is to produce the clinical practice guidelines. So we bring some expertise, technical expertise in producing guidelines, but also bring all the experts in neonatology and experts in ophthalmology and nurses as well to produce the clinical practice guidelines. Why clinical practice guidelines are so important? The reason is because those are the foundation for evidence-based decision making. I mean, That's like a guide for everything. Usually the government uses it to inform development of policies. Very importantly, it sets the standards of care and improve quality of the care of patients. Define which services are covered by the insurance or by the health systems. And of course, regulatory frameworks for licensing requirements. For example, a neonatal unit should follow these guidelines to get the license to function. So it's extremely useful in many ways to improve quality of care. So that's something that needs to be done at some point during the program development process. Next. I just want to, sorry, I just want to talk about the guidelines, how it is done. So the first thing that you have to do when developing a guideline is to develop the questions. And of course, the first question is, what is the association between specific risk factors and the development of ROP compared to newborns not exposed or with protective factors? What I mean with that, you have to have population, which in this case is premature infants. You have to have the intervention, which is the exposure or the no exposure or the protective factors, either way. And then to compare those with the risk factors exposure with those with no protective factors. So the comparison is extremely important in the PICO questions to develop them. And then, of course, the outcomes. The outcomes would be different kind of outcomes. In this question specifically, is the development of ROP is the outcome that we are going to measure. Next one. I put here some questions that are useful in the guidelines. For example, this is the second question, which is, what is the effectiveness of ROP screening in preventing blindness in children compared to no screening? So that's a way of formulating the PICO question, because a Ministry of Health will ask us why I should do in screening or support screening. Well, we have to answer the question, say, well, because doing the screening is better in preventing blindness than not doing a screening. So that's a reason why you have to use comparisons in these kind of questions for the clinical practice guidelines. The same with the technique of the screening. You have to say if it is indirect ophthalmoscopy or retinal images and what is accurate and cost effective. So in every question, you give all the arguments to choose a policy in that. And in that time, in terms of effectiveness of treatment, of course, if it is laser or injections, compared to delayed treatment or no treatment, which is better to prevent blindness? So then if the answer of the question is given, then we can convince governments or insurance companies, whatever, to support treatments in their own policies. So the clinical signs, for example, that indicate the need for treatment is also important to do it. And of course, the clinical indicators that suggest a need for follow-up treatment. So all of those are the topics that you have to include in a clinical practice guideline. Of course, these questions can be modified according to the local realities, to many, many factors, but has to have that, the population, the intervention, the comparison, and the outcomes. Those 4 factors should be placed in all questions for clinical practice guidelines. Siguiente. Sorry, next.
Yeah. Juan, we'll just have maybe 2 more minutes, if that's okay. Correct. Okay,
then we have to choose the methodology to do systematic review, assessing the quality of evidence, and then the final recommendations. Next. then we have to monitor which countries are doing policy mandatory the exam and covering the cost, and the provinces in each country that are really implementing the program next. In here, you then start to measure the proportion of eligible preterm that were screened. So with the coverage of screening next. In here, we have in Colombia a monitoring program, because we realize that once we have the guidelines and the policies, the cities comply with those, but the rural areas not, perhaps because social determinants. So you have to encourage them and to support them in a mentoring program to make sure that not just in the large cities, but in the rural areas, the guidelines are implemented. Next. The same in Guatemala, we tested the fundus photography read by the ophthalmologist, which really increased the coverage of even of treatment. You see in the right part of the slide, the number of children that were treated and in those remote areas using photographs. Next. In this case of Argentina, you see how the median birth weight in grams were reduced through the years since 2004 to 2023. So that's an impact of the program. So the babies were smaller, getting ROP were smaller than before, the same with gestational age. Next. You see here the number of blind children in Argentina. Here at the beginning, they start to rise, of course, as Claire explained it in the first presentation, and then it started to decline as a result of the program, which is started in the blue arrow. The program started at that point in time in 2004, and you see how it declined. So this is the real impact, is the reduction of blind children due to ROP. Next one. Our conclusions, but we can have more, is that the milestones are benchmark that break down the larger goals. It is important to have step by step and a component by component build it up, and in that way you finally get the outcomes. The evidence, of course, is the foundation for prioritization and advocacy, and of course, to make sense of any accomplishment. And the national clinical guidelines clinical practice guidelines set standards, are essential to set standards, inform the development of policies, and define which services are covered by the policies. So that's essential, absolutely essential. This last slide, I belong to the National Association of Epidemiology in Colombia, and we will be hosting the Global Congress on Epidemiology in 2027. So we hope at least some of you will come and talk about epidemiology on ROP. Thank you very much.
Thank you very much, Dr. Juan Carlos. I am now going to go introduce our next speaker, who is actually, unfortunately, not been able to be with us today, but he has sent a report of his presentation. He is Dr. Anand Vinikar. He's a professor and head of department at Nethralaya Eye Institute in Bangalore, India. And he is also the founder and program director of a really groundbreaking ROP initiative, which is called KidRock. KidRock is India's first tele-ROP program, screening for ROP in rural areas. And it's currently the largest ROP program in the world, covering 172 NICUs, and has completed over 300,000 ROP screening sessions and counting. So we'll go on now to the recording of our Dr. Anand's presentation.
Hello, everybody, and thank you for this opportunity. Today, I'm going to share our experience of running a telemedicine program in ROP in India. Well, about 12 years ago, India led the number of countries in number of preterm births and survivals. In 2023, looks like we haven't really changed that static. We're still over 3 million babies, preterm babies, who are born and who survive. This means that our ROP burden is huge. Every 2 hours, 3 babies somewhere in India possibly require treatment. In this editorial, we address some of the reasons why we are seeing this very large epidemic. One of the reasons, of course, was lack of awareness, but also the fact that survival has improved and has increased. So what would we do in a situation where there are very few ROP specialists and a lot of babies to be screened? So this was our model that we started in 2007, the KidROP model, where we aimed to replace the so-called ROP specialist with trained, accredited imagers. This works as a public-private partnership where we engage with the government and provide free screening and treatment into the government hospitals. Our journey has been slow but steady. We started off with 3 hospitals, 3 NICUs, and have now moved to around 174 in 2024, covering a population of about 64 million. Our financial model is one of cross-subsidy, where we charge those who come out of private hospitals and continue to do free service for those who cannot afford it and who are born in government hospitals. Well, back then we used the RedCam shuttle. This was taken into the NICU and used by our trained technicians who were uploading these images and who are also making the initial triage of diagnosis. This is the first Apple iPhone, and we were able to see these images on the go. The triage that these technicians do are one of 3, that the baby needs treatment, the baby needs follow-up, or the baby is completely normal. And to declare a baby normal, we have set the paradigm that one of these imaging sessions between 40 and 44 weeks of postmenstrual age must image the ora serrata. Our turnaround time is less than 15 minutes, even with the low internet speeds back then in our rural villages. Of course, this has changed with India having 5G across the country. We have been validated by the United Nations Development Programme and by the Australian government on the CDC platform, where they report that using imaging is probably the way to go forward instead of indirect ophthalmoscopy performed by inadequately trained ophthalmologists. This led to the imaging scheme of things to be incorporated within the national operational guidelines for ROP, making India the first country to allow trained technicians, accredited technicians, to be the ones who are doing this screening, especially in the rural outreach. We also developed a parallel training program, which was in fact conceived before the pandemic, where the number of days that these trainees spend with us on site is reduced, and the rest of their training happens on site in their at their neonatal intensive care units. We tried to, of course, using the RedCam shuttle and scaling up this program was not going to be possible. So we worked with local industry, and as you know, this is the Forus Neo camera, which subsequently now has the FDA and CE approval. It's much more portable and, of course, lighter and it's easier to use. We compared it in this publication. Their new iteration also has the angiography unit, which is very useful in the era of anti-VEGF injections. We continue to work with stakeholders. This began in 2013 by the constitution of the National Task Force with the help of the Queen's Diamond Jubilee Trust. In 2016, we formed the Indian ROP Society, initiating it with just 8 charter members. We have now grown to about 240. One of the things that we're really proud of is how we managed to modify these screening guidelines during the pandemic, and our own successful outcome in the KidROP, where we were able to continue screening during the pandemic, has been recently published. I'd like to end with 2 recent advances that we are working with at KidROP. Firstly, we are now able to take the tears of these babies and using the biomarkers we find in them, able to predict which of these babies will develop the disease and which of these babies might even require treatment. And this is used as a prediction model. These are some of our publications that address this very challenging and exciting topic. The other one is, of course, artificial intelligence. Because we have so many images, we must work on it being automated, especially if we're expecting healthcare workers and trained technicians to be imaging this as the program scales up. We now have the ability of discerning a stage 2 and a stage 3. We're also working on low-cost OCT, portable OCT device. When you look at the impact, one can look at the 29 districts where we were screening, and we saw no unscreened stage 5 in 7 consecutive years, compared to 18 stage 5s from one district where we were not screening initially. These are a list of some of the countries that have been mentored, trained, and continue to work with KidDrop. In our own country, we have expanded the KidDrop model into 6 of these states where we continue to handhold them and also help them set up and maintain. Well, let's look at the impact that we can make by multiplying the number of babies we have prevented from blindness into the per capita income, into the life expectancy using the WHO formula. We have approximately prevented around $5 billion of blindness. But this may seem like a large number, but it's only a small drop in the ocean. We must learn from the success of the polio eradication program. This paper with a few neonatologists was published in the Lancet, where the success of the polio program, perhaps we can duplicate that and use it in retinopathy or prematurity. So as we scale up and scale forward, we'd like more and more organizations to help us achieve our dream so that no baby becomes blind from this really preventable cause of ROP blindness. Thank you once again for this opportunity and wishing the meeting a great success. Thank you.
Great, thank you for that very impactful and succinct talk by Dr. Anand. And I just want to thank once again all of our incredible speakers. We've learned about the significant burden of ROP and innovative approaches developed to address it. We've seen how Africa's networks are driving really meaningful change, and how Latin America has really implemented effective follow-up and learning systems. And we've just now learned really valuable lessons from India's really innovative telemedicine model in ROP care. And these success stories and the challenges from all the diverse regions really kind of highlight that key point that preventing blindness in premature babies really needs a coordinated, multidisciplinary approach, both within the healthcare team and also with parents and policymakers. And just in the last maybe couple of minutes, I thought I would thank everyone for all the questions, which we are currently being answering in the chat box by all the speakers. I was going to ask our speakers for one key action point that they can give to everyone attending to reduce ROP blindness that they can do now, whether they're a neonatal nurse or a neonatal doctor or a policymaker. So maybe if we just have 30 seconds from each speaker as a kind of a final point, I will hand over to them for the final words. So maybe starting with Professor Claire, would you like to just give one key point?
I think I would reiterate what Anand said about prevention. It is so critical. It requires quality improvement initiatives, which can be difficult, but there is evidence of how taking a systems approach can improve the quality of neonatal care. And this is what NEST 360 is all about. So it's great.
Thank you, Claire. And now very quickly on to Dupe.
Africa, ROP is with us. Just go and look. Ask 2 questions. What weight of baby survive in your NICU? And what can you do when they survive and they have ROP? Start screening, look at your data. Thank you.
Thank you, Dupe. And also then finally, Dr. Juan Carlos.
Yes, I think, my message is develop evidence on the magnitude of the problem, then develop policies, especially financing and the mandatory screening. And lastly, measure the progress of the program and try to include most of the neonatal units or as more neonatal units as you can, and that will follow on the achievement. That's extremely important. Thank you.
Yeah, thank you all. And I think that's the key point, that for everyone attending here, there is practical things you can do in your own healthcare setting to ensure screening and identifying at-risk infants, and also for all of us, the role of advocating to prioritize ROP in both our hospitals and in our national health strategies as well. I'm just going to finish now, conclude this seminar, which has been an incredible kind of road through the whole of global ROP. I'm going to thank you for joining us today. Say that you can, again, these are, you can, I think, get the recording for the webinar here. and share it with your colleagues who've been unable to attend. There's also future webinars for NEST 360. I think next one being on the 12th of November. And I just want to finish by thanking you all. Thanking the funders, I should say, from NEST 360 and all, and also thanking all of you now for your participation. Thanks very much.